Welcome back, students, to part 142 of our IPDRG Masterclass. I'm Harshal, your lead instructor. Last time, in part 141, we wrapped up our executive masterclass on auditing, CDI strategy, and revenue integrity. Well, today we're building right on top of that foundation and shifting gears straight to the front lines of defense. In this Capstone explainer, we are going to dissect the clinical audit protocols for our absolute most critical service lines: sepsis, cardiac, and surgical DRGs. This is exactly where clinical documentation improvement, or CDI, collides with revenue integrity. But before we jump in, a quick reminder. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is literally what keeps this masterclass going. Okay, let's map out exactly what we're covering today. We'll start with the payer scrutiny landscape, then dive into our specific protocols for sepsis, cardiac, and surgical cases, and finally, we'll wrap up with CDI defense workflows. Let's kick things off with Section 1, the payer scrutiny landscape. If we're going to win the revenue game, we absolutely have to understand the primary threats out there. Right now, recovery audit contractors and commercial payer AI systems are actively hunting for payment errors. They are specifically targeting whether a provider's documentation truly supports the assigned MSDRG. And honestly, this puts coders on a very precarious tightrope. On one hand, you have upcoding. Assigning a higher MSDRG than the documentation legally supports triggers massive compliance risks and False Claims Act fines. But on the other hand, undercoding bleeds legitimate hospital revenue. It falsely lowers your case mix index anytime vague documentation forces you to drop a perfectly valid CC or MCC. Take a look at how this DRG triplet structure breaks down. The reason payers scrutinize secondary diagnoses so heavily is because shifting a patient from a DRG without CC/MCC up to a DRG with MCC completely transforms the financial outcome. It is a massive jump. And this is exactly why auditors are zooming in on clinical validation for these higher-weighted tiers. Moving right along to our second section, sepsis and infectious disease audit protocols. Listen, the absolute golden rule here is documentation integrity. You simply cannot assume sepsis just because a provider jots down implicit sepsis 3 indicators, like, say, pneumonia combined with an acute change in mental status and an elevated lactate. That's not enough. You need explicit words like sepsis or severe sepsis to compliantly assign those powerful A40 or A41 codes. If the diagnosis is only implied by the clinical picture, you have to query the physician. No exceptions. Now, once you actually get that explicit documentation, you've got to follow a really strict 4-step sequencing logic. First, you code the underlying infection, something like E. coli. Second, you code the severe sepsis indicator. Third, you capture the specific organ dysfunctions, like acute kidney injury. And fourth, you sequence them correctly, meaning the infection always goes first. If you follow this evidence-based logic, it completely removes ambiguity. You're basically building an ironclad appeal dossier that prevents Medicare administrative contractors from ever downgrading your claim. All right, Section 3. Let's talk about cardiac and vascular DRG audit protocols. Cardiac DRGs are incredibly high-frequency and high-dollar targets, which means we have to meticulously dissect our cardiovascular cases. For example, you must precisely distinguish between these 5 different types of myocardial infarctions. A type 2 MI, which happens due to demand ischemia, influences your principal diagnosis completely differently than a type 1 spontaneous plaque rupture. Plus, auditors are going to heavily scrutinize any secondary coding for acute decompensated heart failure or post-infarction arrhythmias. Getting any of these details wrong pretty much guarantees a claim denial or an immediate downgrade. And it's not just about the diagnosis, right? You've got to map the anatomy perfectly. With the introduction of new MSDRGs, like 209 for complex aortic arch procedures, coders have to chart the exact placement of branched or fenestrated devices across very specific aortic zones. Combining these devices with bypass procedures into the innominate or subclavian arteries is what actually dictates your root operation accuracy in ICD-10 PCS. Speaking of root operations, here is a massive trap you need to avoid. Never misunderstand a PTCA, a percutaneous transluminal coronary angioplasty. The base root operation for that is dilation. However, if a directional or rotational atherectomy is performed at the exact same time to physically remove plaque, it has to be coded separately using the root operation extirpation. Missing that critical detail misrepresents the surgical complexity and completely skews your MSDRG mapping. Let's pivot to Section 4, high-volume surgical audit protocols. When we're dealing with high-dollar surgical variances, things like major joint replacements, spinal fusions, or exploratory laparotomies, passing the 2-midnight rule for inpatient medical necessity is really just step 1. Step 2 is mastering your PCS definitions. Coders frequently trigger audits by confusing these two foundational terms. Excision is the removal of a small portion of a body part. Think of a breast lumpectomy or a liver biopsy. Resection, on the other hand, is the removal of the entire body part, like a total mastectomy. Mixing these up totally derails your DRG pathway. To actually survive these surgical audits, you also have to perfectly match the surgeon's operative report to one of these exactly 7 PCS approaches. Whether it's an open approach for a laparotomy or a percutaneous endoscopic approach for a laparoscopic-assisted cholecystectomy, precision here is non-negotiable. If the operative report is even slightly vague, you've got to query the surgeon before dropping that bell. Which brings us to Section 5, CDI Audit Defense Workflows. So, knowing all these traps in sepsis, cardiac, and surgical coding, how do we proactively defend against this payer scrutiny before the final bill even drops? Your primary weapon here is the concurrent query. You deploy this while the patient is still hospitalized. It needs to be raised immediately if the attending physician's documentation hits any of these 5 triggers. If it's incomplete, conflicting, ambiguous, inconsistent, or unsupported by the clinical indicators. Trust me, resolving these issues concurrently saves you from a massive, massive headache retrospectively. This is where establishing focused clinical audit worksheets comes into play. By using these, CDI teams can perform what we call ethical optimization. Just look at the difference here. Upgrading a generic pneumonia to pneumonia due to Klebsiella, or changing a basic sepsis to severe sepsis with acute renal failure isn't just better medicine. It accurately captures the true severity of illness and firmly secures the revenue the hospital has legitimately earned for treating a critically ill patient. To put this into perspective financially, think about this number. If a patient is admitted with sepsis, but the provider also explicitly documents a present on admission MCC, like diabetic ketoacidosis, it can elevate the DRG's relative weight to exactly 1.9015. Compared to a baseline pneumonia DRG, this explicitly documented clinical reality can literally double the hospital's reimbursement for that exact same patient encounter. And that leads us to our final section, summary and next steps. We really covered a ton of highly technical ground today regarding revenue integrity, coding compliance, and exactly where payer AI is hunting for vulnerabilities. To sum it all up, mastering these high-risk protocols across sepsis, cardiac, and surgical service lines is the absolute foundation of a bulletproof appeal dossier. You've got to capture specificity, you must sequence flawlessly according to the guidelines, and you have to proactively query physicians using non-leading, evidence-based methods. I want you to really think about this question and apply it to your own facility. Are your concurrent query workflows robust enough to catch an implicit sepsis diagnosis before the patient is even discharged? Are you actually catching those gaps concurrently? Get your notes ready for part 143 because we're going to build on everything we learned today and tackle advanced physician advisor integration and concurrent CDI strategy. As always, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you all in the next masterclass, but until then, seriously ask yourself, are you catching those revenue gaps before the patient leaves the building?